Hello, and welcome back to the ASCO Journal of Oncology Practice podcast. This is Dr. Bob Miller of Johns Hopkins. Data published in JOP and elsewhere have confirmed that the majority of oncology practices in the U.S. have implemented electronic health records in the last few years. Certainly, the meaningful use incentive dollars have been one driving force behind this, particularly the desire to avoid the penalties that kick in starting 2015. But other reasons include a genuine desire to improve the efficiency and safety of oncology care and to make it more evidence-based. For this podcast, we're going to be talking about a paper from Adelson and colleagues published in the JOP looking at their experience in implementing the Beacon electronic chemotherapy ordering system, part of EPIC, at the Tisch Cancer Institute at Mount Sinai in New York. Dr. Adelson was gracious enough to join me this evening to talk about their work. She is a breast cancer oncologist and clinical researcher at Mount Sinai. Her other interests include the quality of cancer care and the impact the changing economic environment will have on the practice of cancer medicine. Also, I'm going to acknowledge that I have a vested interest in this topic since my own institution went live with EPIC this summer, and we are hoping to begin our own Beacon build sometime in the next year. Welcome to you, Dr. Adelson.
Thank you for having me.
So let me ask you first a little bit about the background and setting. Can you tell me a little bit about your clinic structure at Mount Sinai? And with Beacon, did you implement the basic EPIC software first and then Beacon, or was it simultaneous?
We began with the ambulatory build and go live probably an entire year before we went live with Beacon. In addition, we did the inpatient build of both clinical documentation and ordering. Took another probably 10 to 12 months before we actually went live with Beacon.
So I think it might be surprising to some that it takes that long to make a go live happen. In your paper, you talk about your build team. Can you describe the process that you use to create the regimen order sets?
Absolutely. So I think a little history is always important. So prior to building Beacon, the oncologists in our practice were able to handwrite orders. There was no way to enforce that the orders were based in the literature. They were often difficult to read. I think the pharmacists just struggled with legibility and even with the evidence behind the regimens that were being given them.
Sure.
And there was very, very little way to actually quantify the kind of care that we were given. So approximately 14 months before we went live, we formed a chemotherapy council. And on the council, there was oncology physician leadership, which was absolutely key to the success of this implementation, nursing leadership and management, and pharmacy leadership. And then we formed a Beacon-trained build team who came to the same chemotherapy council meetings, which included an oncology nurse who had been trained in the EPIC platform and two chemotherapy pharmacists, one who had ambulatory expertise and one who had inpatient expertise.
Uh-huh. Were these, the pharmacists and the nurse, were these Mount Sinai people originally, or were they people that were brought in from the outside?
The pharmacists were long-standing Mount Sinai employees, and the nurse was actually recruited for this position. The training was given to them after they came on board the Beacon project. They took multiple trips to Wisconsin.
I see. Now, in terms of the different disease group, tell me a little bit about that process.
I think there was a general belief that electronic orders would improve and facilitate care. The key to a successful go live is to have a thorough enough chemotherapy order set library to give the teams the regimens they need to use. I would say the biggest challenge is that we requested each group to submit their most commonly used regimens, and that actually eventually involved to all of their regimens. And some of the groups submitted regimens that really weren't supported in the literature, or regimens from a clinical trial comparing treatment A to B where B was inferior, they would submit regimen B. And so by having oncology leadership on board, we were able to say, no, we will not build this if the literature to support it is not good. We used NCCN templates whenever possible, but very, very frequently went back to the original articles.
Who was the final authority? Was it the Chemotherapy Council?
It was the council as a whole.
I see. What about investigational regimens? Was this part of your build?
So not initially, it was just beyond the scope. Epic continually said that, research was not part of their scope. In the end, we've absolutely had to build out all of our research protocols, but we started with just the most commonly clinically used protocols and kept research on paper probably for an additional 8 months, 10 months after go live, and since then have built all the regimens.
Gotcha.
We went live with pediatrics later at all. The pediatric build is very, very similar to the research build, perhaps even more complicated because pediatric protocols are basically all research-based protocols with multiple arms.
How about oral chemotherapy or other oral antineoplastics? Are there specific order sets?
That is an area, no. And that's an area that I think we could do more. One of the limitations with oral chemotherapy is that they tend to be filled by these specialty pharmacies. So even if you were to build an order set, we're not filling the drugs. And so it's going outside, and you end up having to do duplicate work by filling out these specialty pharmacies' paperwork requirements. And so we have not focused on that. But increasingly, ASCO and ONS are calling for better documentation of oral chemotherapy. And so we're starting to look at different documentation templates just to document what patients are taking and show that we've been reviewing it.
I'm curious what the change control process is. So you went to the different disease groups and you got the regimens, and then I guess your builders built them at that point. Did you go back and forth with the different groups, or?
So, yep, there was back and forth. It was a little more complicated. So we started with, I think we started with bone marrow transplant and leukemia. They submitted their regimens. Sometimes they would submit papers, and sometimes the pharmacists were trying to find the papers themselves. We tried to put the burden of that as much as possible onto the disease groups, but our pharmacists were just really motivated and I think made it very easy for the different disease groups. So we would pull the literature, review the literature, make sure that the regimen requested matched the reference. We would look up the level of immunogenicity and then build in standard order sets based on the NCCN guidelines for that degree of immunogenicity. And then we built paper templates. The pharmacist would actually create the paper templates, and those would come back to the chemotherapy council at the meeting the next week. And we would review those. And those paper templates would then be validated by the individual disease groups. We then made the paper templates, so still nothing built, but we made the paper templates available in the EMR through a link in Epic so that we could immediately start using them because they were so far superior to the handwritten orders that we had been getting for so many years. And the paper templates served as the basis for what the chemotherapy pharmacist and I would say our Beacon pharmacist and our Beacon nurse used to build all the electronic protocols. So a lot of it was happening at the same time. We would be working on paper sets for one group and the electronic build for the group that had been one step ahead.
So the paper templates were like a forms on demand type thing. They were PDFs, I assume, that could be printed from Epic.
Exactly. Yep. PDFs separated by disease group and by name and title. And we actually still have those available in case we ever have downtime.
We know that never happens.
We haven't had to call on them too much, actually.
That's good. That's good.
Yeah.
In your paper, you talk about a new metric, at least new to me, called the rate of evidence-based adherence, or REBA. Can you talk a little bit about that? What were you looking to measure with that, and how did you do the calculation of the modified or non-evidence-based regimens?
The idea came from the desire to try to quantify how adherent we were to clinical evidence. And assuming that before we went go live, we had no way to even, before our go live with Beacon, we had no way to even know how adherent we were. And along with the clinical pathway literature, people tend to aim for about 80% adherence with clinical pathways. Measuring the REBA is a step before actually using clinical pathways. And it's a way to say whether or not different disease groups, different physicians, and actually our practice as a whole, or our cancer center as a whole, is prescribing chemotherapy that's in line with clinical evidence. So we said that because we were so stringent with our guidelines in our chemotherapy council, every regimen we built was evidence-based. And we could look at modifications to different regimens or to all the regimens before they had ever been given as a surrogate for not adhering with clinical evidence. So if you change a regimen in the second or third cycle, you're likely modifying it due to toxicity. Mm-hmm. We did not want to include that. We were saying docs who did not like the clinically evidence-based regimens who were changing it. And that's what we looked at. And we did see wide variation between some disease groups and others. And even within individual disease groups, we saw variation between different providers. And so we look at the percentage of protocols that is modified in a ratio. So the numerator is the number of protocols modified, and the denominator is the total number of protocols used. Each time a protocol is used counts as one event. And we came up with this metric.
So what counted as a modification? Was it just a dose, or was it a drug?
So modifications were dose changes, drug deletions, and drug substitutions or drug additions. Carboplatin was a challenge because the way carboplatin is built in Beacon, you have to modify it every single time you use it to take into account the serum creatinine within 72 hours. Mm-hmm. And so initially, our logic was turning up every carboplatin protocol, and we eventually controlled that to only look at deletions or additions of carboplatin, but not dose modifications.
And I think you said this, so anything after the first cycle was not considered in this metric. So exactly. It would be, just to use a ridiculous example, it'd be a provider who said, I don't like the literature RCHOP, I'm going to substitute Novantrone for the Adriamycin.
Exactly.
I see.
Exactly.
Okay. Interesting.
Yeah.
So you also mentioned that the REBA methodology can identify faculty who underutilize clinical evidence. So their prescribing patterns don't meet whatever thresholds you set. How did that work? Did you give them specific feedback to the providers, and was that done systematically? Can you describe that process?
So this is an ongoing discussion. We have not use the REBA in a punitive way at all so far. We have given feedback to different groups and different providers that are frequently changing their regimens as a subject of discussion. And over time, we will look at whether that kind of feedback leads to more adherence. We are considering different approaches, such as issuing a monthly report privately to each different doctor, and even potentially publicly. But we have not gone down that road yet. One interesting thing we saw, you need to use all the different REBA measures. The REBA institution looks at the rate for the entire cancer center. The REBA protocol looks at individual modification rates for specific protocols. Okay. Whoever is using them. The REBA provider looks at variation from one provider to another, and then the REBA group looks at variation from one different disease group to another. When you look at certain groups, we noticed that, for example, one disease group was generally very adherent, but certain protocols were modified every time they used them. And that's a sign that something's wrong with the protocol. And so, for example, in the case of one disease group, they were constantly lowering the dose of docetaxel. And really, they just needed a lower dose regimen built. And so we said, give us the literature and we'll build you a lower dose regimen. Other times you see that there's certain providers who modify all regimens frequently. And, I think that's really a measure of individual provider practice.
And were we talking specifically about combination regimens, or I'm just thinking of the example of, say, metastatic breast cancer, where there's going to be sequential single agents, and the literature is fairly loose about what the right dose is. How was that handled?
So I think we built multiple doses. So, Vinorel being 25 milligrams, Vinorel being 30 milligrams, all of those were already built.
So you had to pick one. So it wasn't, you just said, I'll take the 25 for this.
Exactly. You got to build a library that's robust enough for your practice. And if you haven't done that, then everybody's going to be modifying things a lot.
Yeah. Okay.
And the other thing, when you start looking at the REBA, you got to eliminate the first couple months after go live, because everybody is confused and everybody's modifying everything. And the the head and neck docs are picking breast protocols. And then we saw that, when you cut out the first 3 months, everything started to fall into place and all the numbers looked better and more consistent. And I think that was just a sign of, user adaption.
Talk a little bit about the efficiency metrics that you measured at Go Live. Was there anything that you didn't anticipate?
Absolutely. So, we always talk about wait time and just think about patients waiting outside and getting angry and yelling at their doctors and being unhappy and not being put into the infusion chairs. And I think it can actually be very hard. Cancer centers are so complicated in their workflow. If you think about patients come in, they check in, they get called for a lab, they wait for their CBC result to come back. Then if the result is okay, their chemotherapy orders are released by the nurse. Then they're put in, at some point in this, they're put in a chair and the drug is, dispensed by pharmacy and released and hung with the patient. And so there's many, many different steps where hangups can occur. And what's interesting is we have two different main infusion centers. We have our largest, biggest infusion center in the main cancer center, and then we have a separate breast center. The main infusion center has on-site pharmacists, one of whom actually was one of our Beacon pharmacists. And the breast center uses an off-site satellite pharmacy. And while overall wait time in both places increased following Go Live and then normalized, the increase in the time for pharmacy to dispense the drug was dramatically longer, probably 3 times longer in the breast center, which uses an offsite pharmacy, which is very remote from all clinical activity. They never see the actual clinicians, and the chemotherapy is brought by a runner. Conversely, in the main infusion center, where the pharmacists are constantly interacting with the nurses, they actually minimally increased their time following Go Live and then actually improved to better than baseline. And so by having these multiple timestamps, you can really begin to understand where your hangups are.
Do you think that was the case prior to the electronic health record?
I think that, in the month following Go Live, everything is slowed down a bit. But it's only by having the EHR that you can begin to break down the differences and where the problems are, because finally times are documented. And I do not think that the EHR in itself exacerbated wait times, because they really overall improved. They normalized again following Go Live. So it was no longer slowing us down, but you could understand where you needed to put more effort into streamlining processes.
Now, I was very interested in some of your cost data. You said that the 24-month build phase cost $2.1 million. Mm-hmm. And without asking you to reveal specifics, how much of that was clinician time and salary support, and how much of that was administrative and IT costs? So
about 25% were licensing fees. And there's ongoing licensing fees. The remaining 75% was staff and salary. And so some of that included the physician's champion salary, which is my salary, the full FTE pharmacist salary. Again, we had 2 half-time pharmacists, the Epic nurse, and then multiple different billed IT resources. And so the bulk of the cost overwhelmingly was staff.
And I'm just curious, how many of those folks are continuing in an ongoing capacity? I mean, after the build's done, how much are doing maintenance and enhancement?
So for Beacon, really at this point, I believe we're down to the full FTE for the pharmacist and the full-time Beacon nurse. And we anticipate that we will always need those resources, because there's always new protocols and, new regimens approved, modifications that need to happen, and research studies that need to be built. We no longer have the pure IT build resources or the IT staff.
And yourself as the physician champion, are you continuing in that role?
No. My salary support is gone.
Yeah, funny how that happens. I want to ask you about the provider satisfaction. So your paper shows some very interesting data about how satisfied your providers seem to be with the process. And I'll just speculate that many centers might be jealous of a 76% overall satisfaction rate at 8 months Go Live. What advice would you give to other cancer centers about to embark on an implementation like this?
I am quite sure that our high satisfaction rates were directly related to the depth of our build. So we had this very robust evidence-based protocol library, which had been driven by regimens preferred by all of our practicing clinicians. So they felt that they'd had a say in the process. In addition, we had an unbelievable IT team and really incredibly dedicated, responsive staff who would respond in real time to all the problems we encountered, either immediately following go live and then in the months that followed that. And then prior to our go live, our cancer leadership did a lot to ensure that all patients who were on paper had their paper regimens converted to electronic protocols in the 2 weeks before go live so that we didn't have chaos arise when patients showed up for treatment. So everything was very, very smooth following go live. And I think not having crises at go live enhanced clinicians' comfort with the process.
Was the build team, did they provide ongoing support at go live?
They did. Absolutely. They did. And I think it was 3 weeks. It was either 3 or 6 weeks following go live. I could get back to you. But so we had our in-house IT team who were there supporting us through everything. And then we also had, the Epits who come from Wisconsin supporting us. And then different people who had actually at our institution who were not Beacon experts, but got Beacon trained. They had supported different Epic go lives at the institution, and they came down too as well. They were critical, I think, in helping our nurses because previously our ambulatory nurses had not used an MAR, and this was the first time they did. So we used a lot of resources from the hospital to come support the nurses as they learned to document on the MAR for the first time.
What are the real take-home lessons you want to share with other centers going through an implementation like this?
So I think there's really 4 critical elements in ensuring a successful go live, which I do refer to in the article. But if I was to distill everything, it would be these 4 things. It's extensive involvement of oncology leadership, having a robust chemotherapy council with the authority to enforce evidence-based practice, to raise the standard of the regimens you're building, to have each individual disease group validate every protocol, and in doing so, take ownership for the protocol so that they can't later say the protocol is wrong. And then to have an ongoing collaboration between clinical operations people and information technology regarding the impact of electronic ordering on downstream operations.
Dr. Adelson, thank you very much for sharing your insights and your work with our audience.
Thank you.
Thanks again to my guest, Dr. Kerin Adelson from Mount Sinai, for discussing her experiences with her EHR Go Live. And be sure to check out other articles in the JOP about health IT and electronic health records. To find these, go to the JOP website at jop.ascopubs.org. Look for the header that says Browse by Topic and choose Information Technology. This is Dr. Bob Miller for the Journal of Oncology Practice. Thanks very much for listening.